Now, moving on from flexion distraction, we are moving on to the third section, that is the hyperextension type of injuries. What are the other injuries associated with hyperextension injuries? In this section, we're discussing the hyperextension and double injury, a vulgar injury of the spinous processes as well, and although rare, but yes, we'll be discussing the cervical spine herniation and neuropraxia of the cervical cord. As I told you, the flexion distraction injury can produce facial dislocation and disruption either unilaterally or bilaterally. What does hyperextension injuries do? Hyperextension strains of the soft tissue structures are common and may be caused by comparatively mild acceleration forces. Neck goes into flexion when there is sudden deceleration. For example, if a patient is going in the car and car or gets stuck into another car, again hits another car from behind, that patient will undergo sudden deceleration. This will result in the hyperflexion type of injury to the neck. But if that same person is actually hit by another car from behind, this would produce an acceleration momentarily. This acceleration actually causes the neck to go into a hyperextension type of injury. With hyperextension of the neck, the maximum strain is actually placed on the anterior structure. And anteriorly, there is actually anterior longitudinal ligament or ALL, which is actually the most commonly disrupted ligament. Bone and joint both can be disrupted, but usually associated with facial bruising and lacerations. Compressive extension posterior bony elements may be as well present as well, because once there's excessive hyperextension anteriorly, that means the posterior elements can get compressed and lead to some kind of a fracture as well. So disc and vertebral body may be intact and injuries may be stable, but it may be associated with ligamentous disruption, which makes it unstable as well. With distraction and tension, what is important is the anterior structure fail in tension with tearing of anterior longitudinal ligament, which is most common injury usually associated with hyperextension injury, and there is sprain of ALL. Avulsion fracture of the anterior superior and anterior inferior edge of the vertebral body may be present as well. If you appreciate over here, there is opening anteriorly. That means the anterior ligamentous structure has failed over here. This eventually compression may lead to vertebral body fracture as well, anterior superior or anterior inferiorly as well. This is usually more common in cervical spondylosis, in which there is always associated initially impingement is of the nerve is always there. Then there is a double injury, as there could be associated with whiplash injury as well. Then initially there is a hyperextension leading to the disruption of the anterior longitudinal ligament and may be associated with the disruption of anterior stabilizing structures with hyperflexion. Once the hyperflexion occurs, there is associated posterior ligamentous complex injury as well. And this double injury, it can be leading to whiplash injury as well, in which there is only associated sprain, or this could be associated with vertebral compression fractures and cord can be pinched between the bony spurs and disc and posterior ligamentum flavum. This can cause the acute central cord syndrome as well. And when this happens, this could be the patient may present with the central cord syndrome symptoms leading to neurological compromise. What's important is in hyperextension, if they're stable, they can be treated conservatively, that is with 6 or 8 weeks of semi-rigid collar. But if they're unstable, they need surgical stabilization, and as it is hyperextension injury, the most commonly injured is anterior longitudinal ligament. Therefore, that needs to be repaired and fractures need to be fixed by anterior approach. Now, with high energy trauma, there is always the cervical spine injured at more than one level, and discovery of the most obvious lesion is sometimes dubious. What's important is, importantly, when you see a fracture, you need to look at the cervical spine as a whole. That is, you need the X-ray right from C1, C2, C3, and then all the way to C7, as well as you need to look at the T1 X-ray as well. Because sometimes there may be another associated injury which is present somewhere lower down as well. And this is very common whenever you have a C1 or C2 fracture, then may be associated with C6, C7 lower fracture as well. And sometimes there is subaxial as well as supraaxial spinal fracture as well. Now we are coming to another entity which is although very rare, that is avulsion injury of the spinous processes. These are the spinous processes of the vertebra. Why the C7 actually fails? Because C7 vertebra has a very large spinous process as and after the C2, and usually when there's excessive hyperextension type injury, this can lead to fracture of the or avulsion fracture of the C7 spinous processes. Fracture of the C7 spinal process may occur with severe voluntary contraction of the muscles at the back of the neck. It's also called as Clay-Chauvel's fracture because of hyperextension injury. Injury is painful but harmless. Why? Because this does not lead to any neurological compromise, and plus this does not lead to a lot of posterior ligamentous complex injury as well. Usually the surgical treatment is not required, but sometimes conservative measurement in form of analgesics and symptomatic treatment is required, and semi-rigid collar, a soft collar can be used for the patient as well. As soon as the patient becomes pain-free, the movements of the neck such as flexion, extension, lateral flexion can be started, and neck exercises are actually encouraged, and usually it heals over 6 to 8 weeks over time. Now coming to another entity, although it's rare or less common compared to lumbosacral spine, but cervical disc herniation can occur. And what are the signs symptoms? It can present with severe pain radiating to the upper limbs. Involvement of brachial reflexes may be seen as well. There could be mild paresthesias or weakness. There could be loss of reflex and blunted sensation as well. Rarely the patient presents with a full bone braces, and sometimes there may be associated sympathetic or parasympathetic involvement as well, and patient may present with usually sympathetic involvement leads to Horn syndrome as well. So these all symptoms have to be kept in mind that may be associated with cervical disc herniation. The diagnosis is usually confirmed by MRI because X-rays usually appear normal. CT you don't need to because there's no associated fracture. But when we get an MRI, which actually tells you about the involvement of the nerves which are exiting the intervertebral foramina and what is the status of the nerves as well. There may be sudden paresis need surgical decompression because this may lead to canal compromise. With lesser symptoms and signs, usually conservative treatment is neuromodulators, analgesics, physiotherapy, and all this can be given so that there may be associated radiculopathy or a myelopathy. Once myelopathy starts, you may need to do some kind of surgical stabilization. Surgical stabilization is also indicated when if patient fails to improve with, may require anterior discectomy and interbody fusion as well. And whenever we are dealing with the disc, we have to go through the anterior approach. This could also be associated with neuropraxia of the cervical cord. Usually accidents causing sudden severe axial loading, this could lead to ligamentous sprain. With neck in hyperflexion and hyperextension injuries could be followed by transient pain, paresthesias, and weakness in the limb. Now this neuropraxia could be transient or it could be permanent as well. Usually symptoms could be a few minutes or 2 to 3 days, and pinching of the cord by the bony edges of the mobile spinal cord can lead to radiculopathic symptoms as well. Local compression by infolding the PLL or the posterior longitudinal ligament can also kind of give symptom characteristic of a localized spinal cord compression. There may be the patient may have congenital narrowing, and that is a result leading to ligamentous sprain. This patient may be presenting with those symptoms which are of canal compromise. Treatment consists of reassurances, then graded exercises, and obviously neuromodulators and analgesics as well. And we need to tell the patient that this is a transit process. It will eventually go away and normality will be restored. In this section, we have briefly discussed the cervical spine disc herniation as well as the hyperextension injuries. Although hyperextension injuries are rare, but this usually can be very problematic for the patient because these hyperextension injuries put strain on the anterior ligamentous complex, lead to rupture of the anterior longitudinal ligament, and anterior superior and posterior superior fractures of the vertebral body. If the fractures are stable, they usually require a semi-rigid collar for 6 to 8 weeks, but if they're unstable, they usually require anterior stabilization through anterior approach. And if this is associated with cervical vertebral herniation, Then cervical discs may present initially a radiculopathic symptoms, but once if the symptoms do not go away with conservative treatment, or now the cervical myelopathy has been developed by the patient, well, you will require a surgical decompression through an anterior approach. Thank you very much. Keep watching sqadia.com.